my colleagues and students, friends. It's indeed a great pleasure and honor that I've been invited to give this millennium oration. And I must ask Bala from where he got all this, because I didn't know myself many of it, and let me have a copy so that I can send my CVs like this. I have sent an official CV, and which is all distorted, so I don't know from where you got all that. Thank you very much, Bala, for all that. I think when he told me that this CM is on clinical pediatrics and what kind of topic I should choose, I thought the best topic would be a clinical approach to difficult problems. And I recall many incidences where difficult problems were better solved by clinicians primarily. And if you miss that link, then the investigation took you quite apart from the reality. And I recall having visited once a district place in Maharashtra, where an old man very proudly invited me to see his farm. And when he took me around, he said, "Doctor, you are very well educated, I am not. But I must tell you that education does not bring wisdom." So I said, "Why do you say that?" He said, "My son has become now an MSc and PhD in agriculture." So I said, "That's very good. You have a farm and he is now well trained." He said, "No, that's the problem." I said, "What's the problem?" He said, "We wanted to expand our farm and we wanted some more water." And then my son said that, "Dad, at olden times you used to take a stick and find out where would you get water on the surface. But today we have machines which exactly give you the depth of water." The old man did not believe it, but the son insisted with his great knowledge of PhD that he would rather bring an instrument to see how, at what place in his farm there would be enough water. And rightly so, it was decided to dig at one place. The old man put his stick and said that this is unlikely to hit water. The son did not believe, and still it was done. There was no water at all. The old man asked me, he said, "Are you surprised?" I said, "I don't know." He said, "I'm not surprised at all, because that machine is inanimate and has no brain. This old man has brain even if it's senile. Why do you believe in those machines without brains?" I think he gave me a message that the machines need to be used by human beings after they use their own brains. And I think machines have their own value, but they cannot replace. And I recall a man who suddenly was found to have a baggy eyes, and then he went to an eye specialist. He said there was nothing wrong, his eyes were propped up, maybe an endocrinologist would help. Endocrinologist found nothing but found the veins prominent. She was sent to a cardiologist, and after detailed investigation, the heart was pronounced to be normal. So finally he didn't know where to go. He asked his family physician, and he said, "Well, all tests have been done, many specialists have seen you, maybe your life is now very short." So he decided that he would spend all his money on a world trip, enjoy whatever little life he has, and therefore decided to go and buy a very fancy shirt. And the salesman said, "Sir, what's your collar size?" He said, 14. He said, "No, sir, it's 16. If you wear 14, your eyes will puff up and your veins will stand." He said, "That's my problem." If a salesman could understand what the problem was, we, with great wisdom, did not. I think that's where the clinical story starts. And I'm sure that there is a reason to believe that we'll get better out of equipments only if we use our gray matter to the maximum. Having given you this idea, I'll just take you through live situation that we have seen, where as an undergraduate you did better than a postgraduate, because as an undergraduate you thought your armamentarium was history taking and physical examination. By the time you became a postgraduate, you thought that that was obsolete. Dr. Subara was talking about such clinical material this morning, and we have seen this morning all three sessions where a detailed history and a structured focused clinical examination proved much better. And he asked that what are the reasons why you ask a history, because you get specific information that your investigation won't give. And I think if we go through a structured, detailed history taking and physical examination that we have learned, but we have often forgotten to practice and implement, I think we would be making a mistake. I'll therefore take you through a very basics a basic that we all know, but many times we are overwhelmed by our information and knowledge that we forget the basics, and how if basics forgotten, you have missed a diagnosis very often. We know that the clinical diagnosis, I think, is a prerequisite to solving any problem. If you do not have a provisional diagnosis at the end of the history and a clinical examination, what investigations are you planning without knowledge? It's like searching for a thief without knowing whether there was a theft at all. The police will bring the thief, all right, but you have not solved your problem. And I think, therefore, the first thing that we learned was a patient hearing. An ignorant mother gives you a clue only provided you respect her wisdom and intuition as a mother. And I think many times as pediatricians we have seen a mother is often right, not the most senior acknowledged pediatrician. And I think the patient hearing. And then, of course, the laboratory tests are no substitute at all. And finally, we want the clinical correlation to go by. And I think I'll take you through the whole story as it builds and tell you how in each living case that I'm talking about, the fundamentals if missed, we had missed the whole situation. We said we start with the patient hearing. This was a 4-year child who had fever and cough, and somebody had a chest x-ray done. He didn't know why he was doing, and he was surprised to find multiple air fluid cavities, and then with his great wisdom thought of a staphylococcal pneumonia. Okay, patient was better, but the x-ray was abnormal. Many x-rays were taken, different kinds of diagnosis was given. When I asked the father at the end of several x-rays and several treatments, I said, what is wrong with your child? He said, I refuse to tell you. I said, why? He said, nobody is listening to what I have to say. They just get some x-rays and get some tests, but will you listen to me? I said, yes. He said, the problem is in the abdomen and not in the chest. An ignorant father telling me where the problem is. I was most astonished. Fever, cough, x-rays abnormal, and he said the problem is in the abdomen. He said, take one x-ray of the abdomen, doctor, you will know. I said, what is wrong in the abdomen? He said, in the whole village, there is no child with such a sunken abdomen. It was simply a diaphragmatic hernia. We are talking about the next one, please. And imagine the ignorant father telling me that the problem is in the tummy and the whole abdomen is so shrunken. I think any fool would have called it a diaphragmatic hernia, but no wise person was ready to listen to this ignorant father. Patient hearing. Many times you have had a mother who said, I think my child's ear is paining. You put a hand on the abdomen and say, no, I think it's a colic. Next morning she thanks you, there is no pain now, but there is a pus flowing through the ear. You knew that the mother was right and you were wrong. Time and again this has happened, a patient hearing of the mother. We are told that history begins with name and age. What is there in the name? Age, yes. This is the 2-month-old child. Severe pallor, liver and spleen, not sick. The first child was a thalassemia major and his mother had an antenatal screen. That was told to be having a normal fetus. This is a child with a severe pallor, liver, spleen. You look at the hemoglobin and an HbF. Well, it was enough to know that thalassemia major almost never presents at 2 months of age. Everything looks like a thalassemia major, but for the age of presentation. This was simply a congenital malaria. Parents were upset to be diagnosed as thalassemia major in a second child, even when they had an antenatal screening, convincing them that this fetus was normal. How important the age. We have seen many diseases which are prevalent largely in one age or another. You have a Kawasaki there, you have a Wilson's there, and so on and so forth. While the exceptions are always there in clinical medicine, let us be very sure to follow the rules first. Master the rules, and then maybe at the fag end of your career, rarely, you might have a wisdom to pick up a rare condition. And I think the rule stands therefore. And I always felt that I would teach my son how to cross the road when it is green signal. Having mastered that, then I would teach him a lesson how to cross when the signals are not working. That's also important, otherwise he will wait for the green signal. But as he became adolescent, I once found him crossing even a red signal. That is, he is super consultant. Not always safe. Many times gets through. But the basics would be very much there. And this was an 8-month-old child with recurrent severe asthma. Family history of asthma, wheezing a lot. Again, age is not right to label an asthma, and this was simply an obstruction higher up. This child would vomit, aspirate, wheeze. It was enough to say you are diagnosing a 4-month-old at the end of another 4 months with a recurrent asthma. Age is not in favor. Whereas senior pulmonologists of great wisdom would say, I have seen once an asthma at 4 months of age. That means you have to be that senior and that wise, which we will never be. Why diagnose asthma in infancy? That's enough to begin with. That's how the age mattered. Then we are taught that after the age, the history should start with the chief complaint. While you may have many complaints against your chief, it is important to know what is the chief complaint. Here is the mother who says, I have fever, cough, cold, diarrhea, vomiting. You need to ask her, what's bothering you the most? That's the chief complaint. And I think it's so important. This was an 8-year-old child with severe persistent abdominal pain, high fever, mild diarrhea. Okay. Commonly you see, Dr. Shankar Narayanan is here, fever, pain, abdomen, vomiting, those kinds of things together. But if the abdominal pain is a prominent feature, oh, this may be an appendicitis. Somebody vomits a little, somebody passes 1 or 2 loose stools. So what? I think the chief complaints guide you, and this was a severe cough in a 3-year-old child who had occasional fever, repeated antibiotics, AKT, etc. This child has a chronic adenoiditis. This mother has been talking about a nasal symptom, upper respiratory symptom, a mouth breathing, and adenoid phasia. And you know that every child who comes with a recurrent or a chronic fever cough is just pushed on a tuberculin test and a chest x-ray. And it's so easy. Tuberculin test is often positive without TB. Chest x-ray shows query Hyler without Hylers being there, and so on and so forth. I think we need to know therefore how we would get through that. After we said chief complaint, I think every complaint should have an origin, duration and progress. Nothing new that I say, but often we don't keep on remembering and implementing it. This was a 12-year-old healthy child, high fever and dyspnea over 12 hours. This child was alright, came in the evening from school, had a high fever, started getting breathless. Next morning was admitted in an ICU with an acute breathlessness. He had a neutrophilic leukocytosis. He had a pleural effusion that was stabbed. It was also showing a polymorph. A tube was put in, 2 antibiotics were given. He would not respond. Obviously, how can he respond? Look at the origin. A healthy 12-year-old child develops an acute pleural effusion in 12 hours. In clinical medicine, what happens acutely is either trauma or allergy or a vascular or a neurogenic problem. And therefore, this had to be one of those. This cannot be pneumonia with empyema. It would have taken few days to develop. This child developed acutely. Either could have been a traumatic hemothorax or an allergic pleural effusion of tuberculosis. It was enough to know. This child took 7 days of 2 sets of antibiotics with a tube drainage. All that one missed was that it all came up suddenly in 12 hours. What about those polymorphs? And what about that pleural fluid showing a polymorph? We learned that what is polymorph? Polymorphs are plenty in the peripheral blood. And they are like the constables on the roadside. Constables are there for nothing. They are there when the Bollywood actors come, the cricketers come, the politicians come. They are there when there is a theft, there is a traffic accident, there is even a fire. Their presence doesn't tell us anything at all. They are non-specialists. If a specialist comes in, yes, when a fire engine comes, there is a fire. But even then it could be some monkey trapped on the tree side. Yeah, you never know. So you need to be careful. But for all practical purposes, fire engine is a fire, but not the police constable. He is there all over and he doesn't do anything in particular. So I think that polymorphs doesn't mean an acute infection. It only means the need for an acute rush. And you need to see how this tuberculosis effusion had a polymorphonuclear one, the next one. And therefore, this was simply another one. That one was quickly developing pleural effusion. The next slide, please. This child came at about 7 days of fever, cough, not responding. Somebody did an X-ray. There was nothing much to see. Antibiotics were tried. And the next slide, another 7 days later, when the tests were repeated, a pneumonia came up. They said, good, I was suspecting pneumonia. That would not get better. So what would you do now? Now we are well qualified. If a pneumonia does not get well, we would do intervention. We would do an aspiration, we would do a lung puncture, we would do a bronchial lavage, and we find certainly that there is some staph from the skin that is contaminated. It's sensitive to all, but how can it be sensitive to all? My patient is not all right, so I push on vancomycin or whatever, least forgetting that this pneumonia took 2 weeks to develop. It was a subacutely developing pneumonia, and the next slide shows that there was almost a caseating pneumonia there of a tuberculosis. The tuberculosis came as an acute onset pleural effusion, we missed. And this came slowly as a pneumonia, we took it as pneumonia, we intervened, got a staph, followed the staph, forgot that this pneumonia took such a long time to come up, and this could not have been an acute bacterial pneumonia. A simple fact of looking at the origin. Once we see that we have an origin, progress, etc. seen, don't ignore a clinical setting. For example, you have a 2-month-old fully breastfed baby, comes with diarrhea. First thing that this is not a setting for any pathological diarrhea at all. It could be a diarrhea as per the mother's statement because there are many loose frequent stools, but it cannot be an infection. Don't make a mistake of doing a routine stool examination. You will be obliged by a few pustules. Don't further do a stool culture. There would be an E. coli there. And don't perceive to follow that because the clinical setting cannot be an infection. I recall somebody running in a panic and I said, why are you running? He said, no, I fell down and I got an x-ray done and they said there is a crack on my tibia. I said, I saw you running. How can there be a crack in your tibia? Yeah, but my super specialist said, oh, he may have an absence of pain, congenital absence of pain. Whole life is painful many times. What absence and what congenital? You cry right at birth. So you start with pain, right? Therefore, when I see the fellow running, I said, no, don't worry about an x-ray. I think there's something wrong. He said, but x-ray shows it. I said, then plaster the x-ray but not your leg. Because the problem is with your x-ray and not with your leg. I think this is where probably we don't ignore the setting, and this child had a pathological fracture. A healthy child, while in the recess at the school, fell down, could not get up, had a crack in the spine, a true crack in the spine, couldn't get up. This to the orthopedic surgeon who did not know to see a clinical setting. And therefore he plastered it, a plaster spica, then he started running fever. A plastered fracture patient running fever, infection, so antibiotic. Somebody thereafter did a CBC and found that it was a leukemia. It's not important to know that leukemia causes pathological fracture. It's important to know that a clinical setting on a healthy child who just falls down on the ground while playing cannot just get a fracture of a spine. Either he has an osteoporosis or he has a congenital malformation there or a cyst there. Something that has to be underlining there, and a clinical setting becomes important. Duration is very important. This is a child who was running fever for a year. If somebody runs for a fever for a year and is happy with that 1 year's fever, he has no major disease, that's enough. Now, why he is happy with fever, whether he has really a fever, he has a fictitious fever, or whatever is it, and I know that this was again the parent who kept on saying, sir, whatever antipyretic you give, the fever does not come down. Now, if you ask any undergraduate, which fever does not respond to an antipyretic, oh, you know it's a central fever. But that central thought did not come to our mind at all. Oh, if paracetamol doesn't work, give nimesulide. A banned drug, not banned in India, good enough. Every fever will come down because the child may die. No? Where is the fever there? So, the point is that many times the clues are offered, but we may not pick them up. And this was a child who parents kept on saying no antipyretic work. This was a hypothalamic tumor, and I think it's not important what it is. It's important to know that there is something amiss, and what a way to just pick it up. And then unexpected progress. Many times you have seen a parent come within few hours and say, Doctor, wonderful, your hand and my child gets well. I said, first thing, don't just give a credit to my hand, at least give a credit to my brain. But how can I have a credit to a brain or a hand in few hours? Do you know any condition that gets well in few hours? Only condition that gets well in few hours is no condition existing at all. And I think that is important. And I have seen many times, the next one please. This was a child who came with a typical history of an acute onset high fever, cough, and you had a signs of pneumonia there. Yes, you had a polymorphic leukocytosis, and you had a pneumonia. Surely you had antibiotics on, and you expected within the next 2-3 days a community-acquired pneumonia should start responding. 4 or 5 days down the line of an IV antibiotic, there was no response at all, so a repeat X-ray was done. Thanks. And to surprise, the right-sided pneumonia had disappeared and the left-sided had started coming. A pediatrician changed the antibiotic. I asked him whether which antibiotic works on the right side but doesn't work on the left side. Now, and these are real, genuine cases. Okay, when you look back, you say, my God, even a fool would have thought. But you are not a fool, no? How would you think? So, I think this was another pneumonia. Okay, by now, everybody would have known that there's something amiss. This was a systemic inflammatory response, and Wagner's just run through next 2-3 slides. It doesn't matter. This child came with a hemiplegia finally, and you say, oh, you have a vasculitis there, and you have a pneumonia there. So this was a Wagner's granulomatosis. It's not important that it's Wagner. It's enough to say a right-sided pneumonia gets better and a left-sided comes. I think you are wrong. Your diagnosis is wrong, not the antibiotic wrong. Even if we knew that, and we didn't have to know what was wrong, I think many times it's enough to know there is something wrong, and then you have to know who knows right. That's it. You need not know what is right. And if you did not know what was wrong, what could that right person ever do? You would never see that patient. And I think your and my major issue is to pick up what is wrong and what is right. And I think not that everything would be known to every one of us. It's enough to know there is something amiss, let me ask somebody else. Many times there is a part improvement and you feel happy. This was a child who came with high fever and diarrhea, antibiotics, normal stools next day. If you see any acute GI infection, even bacterial, bacillary dysentery, the fever is the first to disappear, the diarrhea takes time. This child diarrhea got better and the fever continued. Enough to know that there is something going wrong, and this part improvement of diarrhea, and we know that at this age there is a parenteral diarrhea, you have a mastocytitis, you have a meningitis, and surely this was a child with a meningitis, and see what happened after 2-3 sets of antibiotics for so-called GI infection, he ends up with a brain abscesses, and poor child is now living as a clear demonstration of what went wrong with the doctor. And I think such issues that you see make you so much get upset that you had enough clue. And even if you made a first mistake, you had no reason to continue making another mistake and revert back. And I think this is what happened. When a child suddenly improves, you know that he has not improved. And therefore, this was a child who suddenly improved out of a diarrhea, and you know that if a diarrhea improves suddenly, it's not racicabardoctril or one of those fancy ones. I'm sure our GI man says that they are not necessary. And if diarrhea gets better suddenly, there is always a complication, and this child obviously is developing an intussusception, but the diarrhea is all right. Many times the parents come to you with diarrhea and they are very happy that very next moment there is no loose stools at all. Least knowing that if they did not have loose stools, they have far more problem, and this shall develop an intussusception. You know that a paralytic ileus, the toxic, the hypokalemic, many of them would just get into similar situation. Many times the child gets better for a while and then comes back again, a biphasic fever. And we all know that biphasic fevers are of two types largely. One biphasic fever where the second phase is a very mild one, a short one. And that's what happens commonly with many influenza viral infection. But in many other conditions, the second phase is even worse than the first, and that's the immune-mediated phase. And you know how a dengue can fool. I don't have to talk about dengue in Chennai. I think Bala's unit has always dengues of all kinds. Somehow in Mumbai the dengue is different. I don't know why. I feel that whenever there is a clear water, clean water, the dengue cover, and if you miss that, then you have a child in an ICU in a delayed diagnostic stage. And therefore, I think we need to know about that. Having gone through the present history, the chief complaints, origin, duration, progress, we talked about progress when we talked all that. Then you come to the past history. And I think past also gives you a lot of lead to the future. And this was an 8-year-old child, high persistent fever for 8 weeks, no localization, leukocytosis, usual situation. Okay, but what are the past history? Sir, I had nephritis 3 months ago. I get mouth ulcer. I had once pneumonia. Remember that the nature is not so unkind that one child keeps on suffering from different illnesses all along. And I think if this child had different illnesses of different organ involvement, you knew that the basis was a common one. It could be an immune deficiency, it could be a systemic inflammatory, whatever, and this was obviously a collagen vascular disease. That when you saw a child of that kind who had a pneumonia once or a nephritis another time and so on, you know that the common bond should be one different etiology or a pathogenesis, and therefore the past would certainly give you a lead. And having given the past history, then you talk about the personal history. I'm sure gone are the days when, as an undergraduate, personal history diet, vegetarian or non-vegetarian. My teacher used to ask, are you going to call him for a dinner or what? What are you asking, vegetarian or ask him whether he has enough calories or proteins or whatever. And I think the personal history is so important in clinical pediatrics that every time if you ask the mother how the child behaves, I think you know clearly whether you are dealing with a serious condition. Look at the pneumonia child. Okay, you might miss a tachypnea. There may not be a chest in drawing. But if the child looks confused, the child looks drowsy, you already know he is hypoxic. Look at a diarrhea child. If he is irritable or if he is drowsy, you know he has an electrolyte imbalance. Look at a child who is evolving with meningitis. His behavior is changed. And I think behavior is so important. And which mother doesn't know the change in the behavior of her child? She would upfront tell you that, sir, with very high fever he is to play. But today I don't know, he looks different. If a mother says that, you have a serious point on card. And this was a child who came with a persistent vomiting for 3 months. I recall this child at JJ Hospital in my unit, where my resident said, sir, every investigation has been done for a chronic vomiting. He had done a CT scan. What, 10-month-old CT scan for a vomiting alone? He would have been dead long back before he vomited a few days. And then he had an adrenal looking at, and he had a liver, and he had a GI, and a renal, and every organ was picked up. And everything was normal. I said, how can that be? History has always taught us the right path. And he said, sir, I've taken all the history. He had asked whether it's projectile, whether it's bile stain, whether there's an abdominal pain, there's a diarrhea, there's a fever, all that. I said, what about personal history? What personal history? We often don't take a personal history. I think the message is, when you do not know the diagnosis, go in an undergraduate way. And go from system, absolutely a structured history taking. What personal history? When I asked this mother, what about stools? He said, sir, how can a child pass stool? He is not retaining anything, he is so anorexic, he is not. Okay, she is not passing. What about urine? Oh, sir, plenty of urine. Now, if he is not taking anything, he is vomiting, how can he pass lots of urine? Which means he had polyuria. Somebody had to ask him whether he is passing urine. And if you asked her, is urine all right? Yeah, urine is all right. But polyuria. And therefore, this child had polyuria, this child had constipation, this child had anorexia. What about behavior? Sir, he is all the time irritable. I haven't slept for last 3 months. Difficult to manage. The moment I told my postgraduate that you have 5 symptoms to talk of: vomiting, constipation, polyuria, anorexia, irritability. One well-informed, well-read postgraduate said hypercalcemia. That it was. Therefore, in the next week, I had a child who was vomiting for 1 day, and my registrar very proudly said, sir, serum calcium is normal. So the point is that this is just to make a point that a personal history claims the diagnosis. What hypercalcemia physical finding, and what hypercalcemia in the history? Yeah, but it's there in the history. Only if you bother to take personal history correctly. How important is even a small point in the history that you would not miss? Having gone through a history, our teachers always said that when a patient walks in, you look at him and you make a lot. Our neurologists tell me that you don't have to touch a child mostly, you know most of it. Power, tone, coordination, abnormal movements, everything is known by looking at the child before you even make the child cry. All that you want to touch the child is only to take a deep jerk and maybe nothing more. And I think a good neurologist whose clinical skill of observation gives him so much, I'm sure in every part of the clinical medicine and observation. And this was the child with the first look. This was the child, 10-year-old, high fever, dyspnea for 4 days, history of TB contact. I showed you a child of an acute pleural effusion and he had a tuberculous pleural effusion. This was something similar. But remember that tuberculous pleural effusion would be breathless but not sick. This morning we were talking about, somebody said chronically ill child, and Dr. Srinivasan said, where is he ill? He is only chronic but no ill. I think that kind of a look, this child was very, very sick looking. Tuberculous pleural effusion may be dyspneic, but they are not sick looking. This child was a sick looking. That was enough. And then you picked up a cap and it had a blood stain. But you are wise and you are well informed and well read. Sir, sometimes in tuberculosis also you may get a blood stained fluid. Yeah, sometimes, but mostly not, right? And he is sick. This was a malignant pleural effusion, a huge effusion. The next slide, please. And therefore you had to do a CT scan to pick up a huge tumor there, which was in hiding. But there was enough clue at the first look to say, oh, why is this tuberculous effusion fellow looking so sick? Of course, then he was pale too. And I think the first look that he was sick would have cautioned me to say, but this is not my usual tuberculous effusion. But there was a history of TB contact. Those who have TB contact may also get malignancy, we know that. And who doesn't have a TB contact? Yeah, every one of us. A close contact, yeah. Many times when my residents say, sir, there is a family history of TB. 40 years ago, grandfather died of TB. I know, family history means what, isn't it? You don't blame the family for everything that happens. After all, if you fail in DNB, he said, no, family history. Okay, that's not true. The next one, please. Having seen a first look, then you do a general examination. Many times a general examination is very special. And I remember this child, a day 2 child admitted at JJ hospital and lethargic, not feeding, drowsy, neonatal sepsis. My resident said, sir, I've sent a septic screen and I've started to antibiotic. And I said, how is he doing? He said, 2 days have passed, he's neither deteriorating nor improving. Oh, the sepsis is very kind to this neonate because he's neither improving nor doing. By then the septic screen, you know what is septic screen? It doesn't screen sepsis at all. Okay, after all, we were impressed by those 5 things and gradually one by one is getting away. And last time I met a neonatologist from Kerala, he told me that a better screen is what he called as STOPS. And Palni Raman knows that. And this man said that STOPS is S for sensorium, T for temperature, O for oxygen, P for perfusion, S for sugar. He said, sir, do STOPS every time you know whether the fellow is sepsis. What a wisdom of observation. It needs to be validated, but by the time we are told that those septic screen in laboratory may be positive without sepsis and may be negative in spite of sepsis, I think you have a clinical observation. And the best way is STOPS can be repeated every 4 hours. You can't do a septic screen every 4 hours. So there are limitations. This child, when I examined, I said, why is he not deteriorating nor improving? The first thing that was clear was his heart rate was so slow. The moment I said heart rate slow, he said, oh, I should have done an ECG. There could be a heart block. No, this child is drowsy, not feeding, not deteriorating, and therefore this was an euthyroid. It's not important to pick up an euthyroid. I know an endocrinologist who can, on clinical examination, say, oh, I don't think there is enough thyroid. I can't make out that at all. I can't make out an enlarged thyroid. What I can make out an absent thyroid. But that is not important. But I can make out a pulse rate. And everybody knows that the initial is a systemic inflammatory response. You have a tachycardia. And haven't we learned from our intensivists that one good clinical finding in every serious condition is the tachycardia. And if you have a tachycardia without anything, and the tachycardia is unexplained, then I know that he is getting into trouble. And I think how simple then, only, and when did you last count pulse rate for a minute? Oh, wait a minute. So, I think that is important. And this child had such a slow heart rate. This was euthyroidic. That's why he was neither deteriorating nor improving, but then by then the brain had already must have gone bad. So how general examination is so special. And then of course we know that breathing is observed, listen, pulmonologists tell us that many times just use your faculties of special senses and you know what is wrong. And this is a 2-month-old child who came with dyspnea, came in the middle of the night, got admitted in ICU because he was tachypnic. What do? When you have nothing clinical, you at least took a X-ray, pulse ox was alright, he was otherwise alright, but he was tachypnic. Now when you have a small child and a chest X-ray, you always imagine there is something. So my resident phoned in the middle of the night and said, "Sir, I think there is a small pneumothorax. Shall I tap?" You know that small pneumothorax can't cause a big respiratory rate increase in an otherwise normal child. This was simply a deep rapid respiration of an acidosis, and we all know how, I recall an 8-year-old child who had a family history of asthma, and this child was breathing fast, and they were nebulizing. He had a diabetic ketoacidosis. And this is the only child I have seen in 40 years who lost life because he came so at the fag end and he was being nebulized for 4 days. He was getting steroid on the top and you saw that he would die before anybody could do anything. I've never seen a diabetes dying otherwise. And I think the point is that many times this child had an obviously normal respiratory finding and you had missed that. And this was another one who had a diarrhea and then became dyspneic. Okay, he had a severe hypokalemic paralysis. What I want to bring out is that many times if you have seen a neurological oration of a muscle paralysis and a child is tachypnic, he may have no depth of respiration and he may not be able to even voice. Most of the children, small infants with tachypnea are crying, irritable, and if you have a voiceless tachypnea, then you know probably that his respiratory muscles are fired and it could be even a diarrhea and a hypokalemia doing that. Having said that, this was an interesting child where we could nail down and lead the diagnosis. This was an 8-year-old who was accidentally detected of cyanosis. He went to his family physician for a fever and cough, and a very astute family physician said, "Fever cough doesn't bother me, but I think you have a little bluish discoloration of your nails. So you better go to a cardiologist." He was directly sent to a cardiologist who confirmed that there was a bit of a tinge of cyanosis, and therefore he said, "Let me go through a physical examination. Heart was normal, echo was normal, ECG, cardiac cath, pulmonary AV fistula. You have to find out the cause of cardiac cyanosis." At the end of all that, the cardiologist announced that the heart is normal. So go back to a pediatrician. That's where we came into picture, and they said, "We don't know, but heart and cardiovascular problems are ruled out." The good clinical examination showed that there was no clubbing at all, and there was only cyanosis. This morning, I think Subbarao talked that cyanosis presentation is a cardiac disease, rarely in a respiratory disease, but a chronic respiratory disease may start demonstrating an early respiratory failure, might have there are enough clues. When you got the history, the mother said that last several months and years now, he refuses to go and play. When I tell him to go to the market and buy, he says, "No, mommy, I'm tired." Oh, he had a clear symptom of a gradual progressive exertional tachypnea coming up, and he had a chronic interstitial lung disease. Point that I want to make is, an astute, well-educated cardiologist could not pick up that there was no clubbing, but there was a cyanosis. Cyanosis without clubbing means that it is a recent onset cyanosis, and a recent onset cyanosis in a late respiratory phase or an acute respiratory phase where you just see a cyanosis and no clubbing. Would the undergraduate not pick up? We are all asked undergraduate clubbing without cyanosis, cyanosis with clubbing, but the cardiologist failed to pick it up. Again, a reminder that as you get to know more and more, you seem to know less and less because the basics are often forgotten. And these are all genuine live cases. And the cardiologist searched all over for a cardiac ailment. And then the next one, please. Stick out the neck. Okay, you know that this morning on a cardiac thing, they discuss about negative findings of neck veins, etc. This was an 8-year-old child, gradual abdominal distension, okay, past history of jaundice, mild icterus, etc. And I think, therefore, you thought that this was the liver disease probably because he had something there. But one had not looked at and I'm sure Shankar Narayan would not forget to look at the veins of every liver child, because that liver may not be a liver disease, and this was a constrictive pericarditis. You had those veins prominent, there was no hepatosecondary reflux, there was an obstruction there, and you could have picked up straight on. Well, many congestive livers may have a mild jaundice too, and that is not common certainly, but that should not take away. And the point is that a detailed examination would warrant that you look at an examination of the neck as well. If you forgot that, you could have done a liver biopsy, or you could have done many things, and I think this is how one may easily get misled. I think at times you have to stretch your imagination, and this was an imagination stretched by my intern. I recall a very prominent intern in my unit who said that, sir, every emergency I will take one patient and follow him up till the end. Normally interns don't come to the wards also. Now this was a fellow who wanted to be a part of our whole process of management, and I was very happy. He got a child who came with an abdominal distension, and my registrar said, this is an ascites, so probably take this, good case for him. This intern next day on rounds tells me that, sir, this is a simple ascites, but I find that his umbilicus is half smiling. Because he was an intern fresh from undergraduate days, and for him smiling umbilicus, stretch umbilicus, was one of the signs of an ascites. And he closely observed and he said, it is half smiling. He didn't know what half smiling means. And that was enough to say that half smiling is an ascites in half the part of the abdomen. So it's not ascites at all. It was a mesenteric cyst. I recall this intern very vividly. What a good observation. That as such, umbilicus is so small, it rarely smiles. And it's half smiling. I think phenomenal observation. It taught us, and I think I want to ensure all students that if we can teach, it's only because you listen to us and you teach us in return. I'm sure all of these teachers know that. We learn so much from you because you ask a funny question and then I say, oh, I didn't know this. So next time I know it. But by then you ask another funny question. So I know how little I know, and each time, and even today I was making some notes because I got so much from each one of them. And Dr. Srinivasan asked me whether I make notes like that. I said, yeah, because some questions that I would not normally ask my postgraduate were asked by these people, and I know, yeah, this is an important question and my students must learn. So next one. This was a child with that kind of a thing. The next one, and the surgeon removed a big mesenteric cyst. An intern could diagnose where many of us could have failed. What's the moral of the story? You need to be an excellent undergraduate before you become a postgraduate. But postgraduate means what? Forgetting graduation, post of that. So, yeah, so I think that's where we, and many times there is a head start. This is a child who came with high fever, and I'm sure all, as pediatricians, we are all used to first put our hand on the skull and palpate an anterior fontanelle. And while doing that, I suddenly found a small projection there on the skull. And this was a child running fever, many tests. When we picked that up, this was a secondary from a neuroblastoma. Again, a detailed examination. At DNB level, I'm sure that you don't forget when you're asked a clinical examination, undress the child, see the child fully. Small issues will give you probably half a mark. Of course, you know by now that you introduce yourself, you ask for a permission whether you can examine. Then while taking the history, you said, which language would you be comfortable? And at the end of that, you say, any more questions? Now, all I think half a mark for each. 2 marks are certain without knowing pediatrics. Another 3 makes you a DNP. So I think don't forget of all that. And I'm sure we in practice have to do that, because otherwise in a general teaching hospital, anybody and everybody can palpate or auscultate anyone any number of times. And I think that kind of a good rapport between the parents, treating them as respectful human beings, and I think is a part of that. And this was a neuroblastoma. I will just end up. There would be many such instances. I just wanted to give a glimpse of how a good history taking and in a very structured way, a detailed history and a very focused clinical examination can make a difficult problem simple. And many times when we are searching for a diagnosis and then we evolve at the end of several investigations, we go back and say, my God, I missed the first stage. I could have just diagnosed it right at looking at the child. oh, doesn't matter if this happened, but I need to learn and again not carry the same. I'll just end up by saying that be it a specialist or super specialist, be it an experienced or wise, even then take clinical history like a newcomer. I think when you don't understand, start afresh like a newcomer and examine like a beginner. Don't do a shortcut examination. Think like an undergraduate, behave like an amateur, and then only you will be a true professional. Thank you very much.